Well, good afternoon, everyone. I'd like to welcome you to our webinar on phone-delivered psychological treatment for children in humanitarian settings. My name is Michael Plus. I'm professor in developmental psychology, and I'll be chairing this webinar. And we will hear from many of my colleagues that have been working with us on this research project. So let me just give you a little bit of a background of our work. Many people are now delivering therapy, psychological treatment over phone because of the pandemic. But a few years ago, when we started working on this, that wasn't the preferred mode of providing treatment. But it was about 5 years ago, or 6 years ago almost, when I was in a refugee camp in Lebanon, that I realized most people do have mobile phones, but most of people or children that need treatment don't receive treatment. So we thought, how about providing treatment over phone? Consequently, we developed a grant. We got this funded by R2HC, and I'm now very pleased to present results from our research. So let me start by talking you through the program, and then we'll get started. So just a second. So we will start with my introduction here, and after that we will hear from Stephanie Skavensky from Hopkins University, and she will provide a basic introduction to t-CETA, the face-to-face version of the treatment that we adapted to delivery over phone. After that, we will provide an introduction to the t-CETA project, the research design, the approach that we took, so that you get an understanding of that. We will then present our research results. It's a mixed methods approach, so we have qualitative and quantitative results that you will be learning about in the presentation that Dr. Fiona McCune from QMEL will present. After that, Dr. Tanya Bosky from American University of Beirut will provide some solutions that we've developed in order to overcome some of the challenges that we've discovered whilst delivering phone therapy. After that, we will have Dr. Fiona McCune again presenting a guidance document that we put together and published last year, not just for t-CETA, but more generally for how to deliver phone therapy. And then after that, we will hear from our colleague at Restart, Joël Werbe, about their practical experience of delivering t-CETA to children over phone in Lebanon. After that, we will hear again from Stephanie Skavensky about what are the next steps that organizations should take if they're interested in delivering t-CETA through their own services. We will then have a 15-minute Q&A section during which we will be able to address your questions. And then we'll end hopefully on time at 3:30. Let me just make a comment about the questions. So at the bottom of your Zoom portal, you have a Q&A tab. So please use that during the presentations. Enter your questions, address them to the specific person that you would like to answer, and then we will try to respond to those questions already during the webinar, but we will then address some of those questions in more detail during the Q&A section. So keep sending us questions and we will keep responding to them. Also, we are recording this webinar, and the recording will be made available on our website as soon as possible. So that's all from me. And I'd like to hand over to Stephanie Skavensky, who will share a bit more about t-CETA.
Great. Thank you so much, Michael. And thank you everyone for joining us today. As Michael said, my name is Stephanie Skavensky, and I'm part of the Applied Mental Health Research Group at Johns Hopkins, but also one of the co-developers of the Common Elements Treatment Approach, or c-CETA for short. And we're just going to start off the webinar by giving a very brief overview of what c-CETA is and why we developed it. So I've been working with the Applied Mental Health Research Group for about 12 years, 10 of which I spent in the field living in Zambia, as well as in other locations, short stints in DRC and Cambodia. And my job is really to train and integrate and implement evidence-based treatments. And one of the the best parts of my job and the things that I love the most is working closely with our field teams and on a weekly basis, working with our supervisors. And I think one of the things that often came up in our work in the field was that our supervisors would come to us with challenges. And one of the big challenges that we saw most frequently is a challenge of clients coming in with multiple different problems, and that they're only trained in one evidence-based treatment and their ability to only treat one thing at a time. And that's the reality in the field. For those of you that are working with clients and working in the field, you know that most of the people that in populations that we work with have many different problems, that it's very rare to see somebody who just has depression or just has violence, that oftentimes people come in with a mix of different symptoms of mental health problems, as well as other behavioral health problems like violence, low adherence, risky sexual behaviors, grief and loss. And so what we do see in the field is comorbidity. And despite this, in mental and behavioral health practice, our approach for treatment is really siloed. What we see is that we often treat one problem at a time, and the interventions that we have address only those problems in those silos. And as a team, we really started to think about, is this the best we can do? What happens with the siloed approach is to treat a population and help them heal, you would have to train, integrate, implement multiple different programs and interventions. And that's challenging at best, if not impossible. And it's also highly costly and unsustainable. Our providers often get overwhelmed with numbers of different trainings and mixing the interventions together. So it causes a lot of challenges in the field.
Stephanie, just quickly, I don't think we
Yeah.
see your slides. If you could activate the slideshow.
Oh, it is. I'm
We
sorry
can see
about
your
that.
slides, but they're not in slideshow.
They're not? That's very strange. Hold on one second. I'm going to stop share. I apologize. Oh, is that better?
That's perfect, yeah.
Okay, sorry about that, everyone. Thanks, Michael. Um, so as I was saying, one solution for silo busting in our field of behavioral and mental health is the common elements treatment approach, or CETA. And CETA is a multi-problem, modular, and customizable approach that's made up of many different elements, and it can treat not just one or two, but multiple different problems like violence, substance use, depression, anxiety, externalizing behaviors in youth, parenting skills. And so, really, what we have then is one provider that is able to treat multiple different problems, making CETA a scalable solution. So, let's take a closer look at CETA. What you'll see on this slide is, for those of you that are working in mental and behavioral health, a lot of words and elements that look really familiar. CETA is not a new treatment. It's built off of existing evidence-based, well-researched elements of cognitive behavioral therapy. And what's different about CETA is that we really teach providers to pick and choose the elements they're going to use based on the client's symptoms and severity of symptoms. So you might have a client that comes in that has very mild symptoms and just is going through a life transition. And in that case, we might just use one or two elements for just a few sessions. Or you might have a client with more moderate to severe symptoms and comorbidity. And in that case, we might choose different elements and have a longer treatment. But what we know about CETA is that it can be effectively delivered by lay providers, and that we can actually teach them to do this clinical decision making. So what makes CETA unique is this point of clinical decision making. And providers, when they have a new client, have to decide on three choice points. They need to decide what elements to use, and that's really based on the client's main symptoms and the primary problem they're coming in with. In what order they should use those elements. So depending on which problem is severe or if there's any interference with the client's functioning or ability to come into session, they might move up certain elements to help with treatment. And then what we call dosing. So how many sessions of each element does a client need? And that's really based on the severity of the symptoms, as well as when the client's progressing. If they're getting better, if they're not, we need to do more. In order to make those choices, we help providers use 3 data points. The first one is an assessment, and this is really just a very simple 1 or 2 page mental health symptom check that we do not only to determine if a client is eligible, but also to monitor progress of treatment to make sure that the client's getting better over time. So they use those results plus what they see and hear from a client in session, and then discussions with their supervisor to talk about what elements they should use and in what order. And as I mentioned, we often work with lay providers, and so the supervision is really important. So to talk a little bit more about that, one of the things that is also really important when we do CETA is how we train and implement it. And for those of you that are in mental health research, I'm sure that you're very aware that one-off trainings, the literature just shows us that they're not very effective. Just going in and doing a live training and leaving doesn't really work. And so you need that ongoing practice and supervision as lay providers are learning this and doing it for the first time. And so we use what we call an apprenticeship model of training. And in the apprenticeship model of training, we do start with that initial live training, but then move into practice groups where providers meet with a supervisor in small groups, practicing the skills that they learned. And then they take on their first client and ongoing clients with support from a supervisor. So really practicing, discussing cases, and problem solving as they go. So that's a very, very brief overview of what CETA is. And if you have more questions, you're welcome to go to cetaglobal.org. We have a lot of information and a lot more information about the intervention there. And you're also welcome to reach out to us at any point if you would like more information. I did want to share just a little bit of the evidence for CETA. So what you'll see in this chart here is just some of the studies that we've done that highlight CETA across many different contexts with different populations. And I think the main point here is just that we see that CETA has a large effect size and is highly effective in treating a range of different problems within these different contexts. So depression, PTSD, dysfunction, violence, substance use. And just looking more specifically at CETA within one of the studies, so we ran several trials in Iraq. So this is a representation of our data from those trials. And I think what you can see is that CETA really does outperform a lot of the focal treatments. So in these studies, we looked at CETA compared to non-specific counseling, so just a psychosocial counseling, cognitive processing therapy, behavioral activation. And you'll see that CETA really had quite large effect sizes on anxiety, PTSD, and depression compared to these focal treatments. And so what you have in CETA is not only the ability to treat multiple problems, but that one provider, that you also have the ability to then train lay providers, because a lot of the settings we work in, there aren't the staff that are needed, that are trained in masters or higher level mental health services. So I'll end with that and hand it over to Michael and Nicholas, who are going to go into the transition of CETA into t-CETA. Thank you.
Thank you very much, Stephanie. So I'll talk a little bit about the t-CETA study from a bigger picture perspective, and then Nicholas Shehadi will share a bit more details. I want to start with the different partners involved in the study. So the study is led by us at Queen Mary University of London, in close collaboration with colleagues at Johns Hopkins University, Médecins du Monde Lebanon, American University of Beirut in Lebanon, as well as the Medical School Hamburg in Germany, and the Institute for Development Research, Advocacy and Applied Care in Lebanon as well. The study is funded by R2HC, which we're very grateful for. And as you can see, there's quite a few people listed here. There's actually quite a few more people involved in that, the independent assessors, the drivers, and all the support staff at Médecins du Monde. So we do know, to give you a bit of background, that children exposed to war are at significantly increased risk for the development of mental health problems. What we also see is that suitable treatment is often not easily available or not easily accessible for those children. And there are various reasons for that, but there's some established reasons I want to mention here. First one, there's a high cost of providing new services. Many of the humanitarian settings, there are limited psychiatric and psychological services. So scaling those up or providing new services are often costly and not possible to do. Secondly, it's difficult to recruit qualified staff with a mental health background. And thirdly, and that's probably the most important one, there's limited mobility of the refugee population. People often struggle to access clinics because there's no public transport. They have to work, they can't just leave. So those are some of the reasons why many of the children that do suffer from mental health problems don't receive the support that they need. So in order to address that, we aimed in our study to adapt the existing treatment t-CETA for delivery over telephone. And then to do that as well with the help of trained lay counselors. So there will be supervisors, you just heard from Stephanie, but there are lay counselors trained to deliver t-CETA. And in the second stage, we then evaluated the feasibility of telephone delivered t-CETA using a randomized controlled trial, but also using a qualitative approach. So let me share a bit more about the research approach. This project is linked to a longitudinal study that we are also conducting in Lebanon, the BioPath study, which has a sample size of 1,595 families. And the sample, this study is funded by NICHD, and the sample for the t-CETA study was recruited from that bigger BioPath study. These were all children that requested, or whose caregivers requested, mental health treatment, and during the BioPath data collection. So we delivered then t-CETA over the telephone or a treatment as usual. And the study has two phases. So in phase one, we recruited staff, trained them, and developed a t-CETA manual. And in the second stage, we piloted the study, the approach in a randomized controlled trial. Let me just quickly share what we did in these different phases. So in phase one, we translated the t-CETA manual into Arabic. We then recruited 2 lay counselors who are on the call with us today. We provided initial t-CETA face-to-face training. So that was done by Stephanie Skavensky and Laura Murray in Lebanon. And they conducted then practice sessions over a period of time. We recruited children with mental health problems, so significant mental health problems. And then we delivered face-to-face t-CETA to a number of children first, so that lay counselors could get familiar with the approach, while at the same time, we were adapting the manual for t-CETA. And then we started first tests with t-CETA with Syrian refugee children that came to the clinic and received phone therapy in the clinic, sitting in a different room than the therapist. In the second stage, we evaluated the feasibility with an RCT. We included a number of children here, 20 children, so it's a very small trial. So they requested services and screened positive for mental health problems during the intake interview. We then randomized these children into either t-CETA or treatment as usual, the treatment that MDM usually provides, and we stratified for age and gender. The assessment team and the data analysis team were blinded for the conditions. And we had two ways of assessment. So we had independent assessments that were done pre and post intervention over the phone. And we had in-session assessments that were conducted by the counselors throughout the treatment at each session. And that's all I share. So I'm handing over to Nicholas.
Thank you, Michael. I am going to walk you through the practical aspect, the implementation of the study in Lebanon. As Stephanie has mentioned, and as Michael has mentioned as well, we recruited lay counselors for the study. The first part of the recruitment process was undergoing practical tests that had questions around case management, case scenarios around ethics and child protection, and then those shortlisted did an interview with one part technical questions and another actual case scenario role plays on the spot with feedback. It was very important for us to focus on feedback because it was a constant learning environment, the study and the job they're doing. Those chosen for the job did a 10-day t-CETA training. Generally, it's a 10-day training with t-CETA with Stephanie Skavinsky from Hopkins University, followed by t-CETA practice sessions. So we had 12 t-CETA components. Basically, we had 12 t-CETA practice sessions, one practice session per component over a period of 2 months. And we did around 2 to 3 sessions per week for 1.5 hours to 2.5 hours per session. Each session had one part theory because it was important for the lay counselors to understand mental health, the symptoms and manifestation, and then another part, the role plays of case scenarios for each component. Once the practice was done, we started recruiting our first participants in the study. Michael, next, please. The recruitment of the participants, during the recruitment had 3 main phases in the study other than the treatment, the t-CETA treatment itself. The phone screening is an initial follow-up phone call for those referred from BioPass. The counselors would ask questions on the phone for the participants around the mental health problems and needs of the child and the caregivers. And once the family and the child met the criteria over the phone and agreed to come to continue this forward, they would be invited for an intake assessment in the clinic. The intake assessment, also done by the lay provider, lay counselors, is the first initial interview face-to-face with the family and the child. The lay counselors would go over the informed consent and assent, the MDM patient intake form. MDM is Médecins du Monde. And we would complete our clinical assessment, which was the mini-kid and the client monitoring form for t-CETA, for screening for symptoms for mental health problems. And last, in the intake assessment, we had the visual aids that supported the eligible families who are recruited in the study and agreed to move forward in their pre-treatment and post-treatment independent assessments over the phone. These phone assessments were done by trained interviewers. They were graduate students in psychology in the American University of Beirut under the supervision of Dr. Tanya Bosky. We asked in the assessment, they asked a set of locally validated mental health tools and measures that we already used in our previous study in BioPath. The lay counselors also followed other than the practice sessions and like when we started the study and the treatment, they followed a rigorous supervision routine. We had 1 to 2 t-CETA clinical supervision sessions per week with the research manager and the lay counselors. We also had 1 intake assessment supervision session per week with Dr. Tanya Bosky, the intake assessment that had the BDKID and the CMF and all of that. The research manager in his turn would have 1 supervision session per week, clinical supervision session per week with Stephanie Skavinsky, our t-CETA trainer. Other than the supervision, we had shadowing sometimes. It was mutual shadowing. Sometimes the research manager shadowed the t-CETA counselor, sometimes the t-CETA counselor shadowed the research manager, depending on the need and the urgency of the case, either during intake assessment or t-CETA session. The participants, can you move forward, please? That's for the CETA, that's for the CETA phase 1, the CETA face-to-face. As Michael said, we had to adapt the manual, the face-to-face CETA manual to t-CETA to be done over the phone. The adaptation process was also fairly rigorous. Johns Hopkins would review the CETA component. They would send us their question. The CETA team in MDM would review the component, adapt, make it more telephone friendly with the activities and steps. We would consult with the mental health Médecins du Monde team. They would send their comments and suggestions. We would then adapt one more time after meeting with them. And we would start the tryouts of the CETA, the adapted t-CETA component with healthy volunteers over the phone, role-playing the component, and adapting furthermore after the role plays, after hearing from their feedback as well. We would then send the first revised draft of the t-CETA component to Johns Hopkins. This adaptation process was continued until the whole t-CETA manual was revised in this manner as a first draft. We then moved forward with our piloting of the t-CETA manual. We invited children also referred from BioPass and who requested help to our clinics, and we completed the t-CETA pilot with children who met the initial inclusion criteria of the study. The child would sit in one room, the counselor in another room, and they would complete the t-CETA treatment over the phone. After the pilot was done, further revision was done for the t-CETA manual and the components, depending on the children and participants' feedback and the supervision sessions as well. And then we moved to evaluate the feasibility of the t-CETA treatment over the phone in a pilot randomized control trial in the setting. Some of the adaptations that we did for the t-CETA manual, we, for example, had to divide the face-to-face, the CETA session in half, the duration. So instead of completing a 1 hour session or 1 hour and 15-minute session between the child and the caregiver, we would make it, we would complete the t-CETA session in 30 minutes. The regular treatment session number is between 8 to 12 CETA sessions. It would have become between 16 to 18 sessions, for example, or 12 to 16 sessions. We used a lot of games and the steps to engage the children. We gamified some of the steps. We used a lot of moment-by-moment monitoring techniques for certain activities. And we also relied on the visual aids that we were only using for the phone assessment. Those are small examples of how we adapted the manual.
Right. Sorry, 1 second. Okay, so I'm going to talk through some of our results now. So we had 4 key research questions that we were interested in. Firstly, is it feasible for lay counsellors to deliver CETA via phone in a humanitarian setting? Is t-CETA acceptable to Syrian children and their caregivers? Does t-CETA help to overcome barriers to children accessing mental health services? And does t-CETA reduce symptoms of mental health problems in children? So I'll first give an overview of the research data that we've got to look at those questions. So we took a mixed methods approach, so we have both quantitative and qualitative data. We conducted a pilot randomized controlled trial, and that gives us 3 main types of data. So we have data on attendance and adherence, and how many children completed treatment and things like that. We also had the in-session assessments that were completed by the counsellors during sessions in order to monitor treatment response. So that was completed during the course of treatment. We also had the independent assessments completed by assessors who were blind to treatment condition before and after treatment. We also have the detailed case and supervision notes, which we're using to write up a case series of children who were offered t-CETA. And we did 2 separate sets of qualitative interviews, which we did thematic content analysis with. We did one set of interviews with the counsellors, and then another set with children and caregivers who had had t-CETA. So they were conducted as two separate analyses, but we were then sort of looking at that together. So I'm going to start with those latter two types of data first in order to look at the first two research questions. So is it feasible for lay counsellors to deliver CETA via phone in a humanitarian setting? We did individual interviews with the counsellors and the supervisors. So you just heard from Nicola and Diana and Stephanie, I think are on the panel today as well. And we were interested in what are the perspectives of counsellors on the delivery of CETA to Syrian refugee children over the telephone. We audio recorded and transcribed those interviews and did thematic content analysis, and Kristen Hadfield primarily worked on that together with Karen Plus. We identified 3 themes in that analysis. So counselling over the phone both solves and creates practical and logistical challenges. t-CETA is adapted to potential cultural blocks, and t-CETA works and is needed. And I'm going to talk about these themes in more detail in a minute, but first of all, I'm just going to jump to the second research question. Is t-CETA acceptable to Syrian children and their caregivers? So we did individual interviews with children who received t-CETA and then also separate interviews with their caregivers. We were asking how did Syrian refugee children and their caregivers experience receiving psychological treatment over the phone. These interviews were audio recorded, transcribed, translated into English, and we did thematic content analysis. So Hania Al-Khatib primarily worked on that together with Kristen and I. And we identified 4 themes in that analysis. So counselling over the phone solves and creates practical and logistical problems. t-CETA works for many families, but there are remaining challenges in some others. The relationship between the counsellor and the child and caregiver was important, and the family's attitude to mental health influences the understanding and engagement with counselling. So you may have already spotted that there's some overlap in the themes that emerged from those 2 analyses. So both counsellors and families identified that counselling over the phone solves problems, but it also creates some new ones. Both identified that t-CETA works in many families, and these 2 themes sort of superficially look different, but there's actually some common ideas there that I'll discuss in a minute. So t-CETA does solve certain problems. Travelling is a big challenge in this context, as Michael was outlining at the start. So phone delivered therapy was seen by families as practical. They said access to therapy is just a lot easier than having to travel to a clinic, and that's because transport is expensive. There's often other children to take care of, and it's not necessarily safe to leave other children in the camp. It takes a long time to travel, and that's difficult if the child attends school or is working or parents are working. There's been periods of road closures and bad weather, so there's many things that make that difficult. And the counsellors noted that telephone delivery reaches more children. It's logistically flexible. You can hold more appointments, and follow up is much, it's much easier, and more. You can follow up more rapidly when sessions have been missed. Another thing that both counsellors and families pointed out is that for some children, it may actually be easier to talk over the phone about sensitive issues. Perhaps when you're, compared to sitting in a room with someone, you can't see the reaction, and for some children that seemed to work a bit better. But t-CETA also creates challenges. So there obviously can be difficulties with calls. There's high phone costs. So we did make sure that we called families rather than expecting them to call us. There can be, so many families will have one phone, so you need to make sure the right person has got access to it. There can be periods with poor network coverage and difficulties with phone charging. Some, not all, but a small number of families had worries about calls being recorded or people spying on them. It can be difficult to achieve privacy in settlements, and also there are the challenges to communication when you don't have visual cues and you can't see the person. And families picked up on some of these things as well, pointing out that there would be a lot of noise, sometimes from siblings or other people in the camp, that would make it difficult to hear. And for children, even keeping the session shorter, some children, especially the younger ones, are more likely to get bored, and it's sort of a bit harder to maintain attention. However, on balance, most families were very accepting of phone delivery, and this is mainly because of the barriers to attending a clinic. This was seen as an acceptable alternative. So t-CETA is adapted to cultural blocks. Counsellors have had prior experience in things like social protection and working with these refugee communities, and that meant they had that local knowledge, which meant they could be sensitive to the context and to people's beliefs about mental health. And also they thought that the phone delivery helped to stigma, because if people are having therapy at home, you know, their neighbours and other members of the community don't necessarily know that they're accessing mental health services, so it can reduce some of those issues with stigma. And also the combination of phone delivery and lay counsellors who are very familiar with the context seem to allow the counsellors to be more informal than would be typical in a normal therapy setting. Maybe just something about not sitting in a formal, you know, therapy setting in a clinic, you know, doing it at home over the phone just allowed them to be a little bit more informal. And it was interesting because many of the families commented on how good a relationship they had with the counsellors. That there was, it seemed, a sense of sort of real rapport that was built up there. So obviously it is possible to build that rapport over the phone. And many of them said that the counsellors made them feel very comfortable and relaxed. So that almost certainly was important in the success of therapy. Some children did find it hard to talk over the phone, especially at the beginning, but that often became easier over time after the first couple of sessions. And families pointed out that the counsellors seemed to be good at picking up when children didn't understand things and would repeat things, explain in different ways, you know, and really work to ensure that the children understood the content. So t-CETA works and is needed. The counsellors were very positive about t-CETA, both from the efficacy and also from the logistical perspective. And they had multiple success stories of children who had quite debilitating mental health problems that seemed to be alleviated through t-CETA. And children often commented that they enjoyed the sessions. Many of the families talked about the fact that the children and caregivers had learned things and they were able to give descriptions of applying those things in real life settings. And that's probably why they reported improvement in a whole range of symptoms across different settings. However, there are major structural environmental challenges faced by refugees, and that's likely to limit the effectiveness of any form of mental health treatment. That's not specific to phone delivery, obviously. And we did find with the family interviews that there seemed to be less improvement where there were substantial other problems in families. So where there was physical ill health or financial difficulties, difficult current living conditions, family separation, lack of access to school and things like that. And finally, the family's attitude to mental health seemed to vary quite a lot between families. So there were some families that didn't seem to experience a lot of stigma, who were keen to seek expert advice, who were supportive of therapy, the caregivers seemed to be involved, and there was overall a sense of a greater commitment to therapy. And with some, I just wanted to point out this quote, someone saying psychological treatment is a treatment like any other treatment that you have to commit to. Part of the psychoeducation component of t-CETA is about using analogies like completing a course of antibiotics. It's important to take all the doses to complete the course, and it's the same with counselling. And some of the caregivers were sort of you know, reporting this back to us, so clearly had taken those ideas on board. So psychoeducation is really important. Some families reported experiencing more stigma, and there was a sense that some of those caregivers were maybe less involved in treatment. And there was also in a small number of families an expectation of perhaps other help, like financial help. And I think we just need to always remember when there's multiple unmet needs that may impact on treatment success, but also the expectations that families have got. So is it feasible for lay counsellors to deliver CETA via phone? So yes, with appropriate cultural adaptation and modification for phone delivery, it does seem to be feasible. Is it acceptable to families? So some families said that they would have preferred face-to-face in therapy in an ideal world. The reality was that they couldn't really travel to clinics. So telephone delivery was seen as an acceptable and effective alternative, and many of them are very positive about that. So does t-CETA help to overcome barriers to accessing mental health services? So we ran a small pilot RCT with 20 children who were randomised to t-CETA or to treatment as usual provided by Médecins du Monde. Of the children who were randomised to t-CETA, 90% had some treatment and 60% completed a course of treatment. The treatment as usual group, 50% accessed some treatment, but no children completed the course. And this is reflected in the total number of sessions delivered as well. So 95 sessions of t-CETA were delivered compared to just over 20 of treatment as usual. For context, the RCT was taking place towards the end of 2019 when there were nationwide protests when the October Revolution started. So that did affect the treatment as usual because there was a period of clinic closures at that point. However, it's of note that we were able to continue to deliver t-CETA and 60% of children completed treatment despite the clinic closures. That was with the counsellors working at home to continue through that period. We can also look at the ratio of completed sessions to missed sessions. So for treatment as usual, this reflects the period before clinic closures. So this is services as they would normally have been operating. And for every completed session, there was close to 2 sessions that were missed. For t-CETA, that was closer to 1-to-1. But it's worth pointing out that for t-CETA, missed sessions are less disruptive because there's just more flexibility with scheduling. You don't necessarily need to wait a full week to schedule another appointment. You can call them back later and things like that. So does t-CETA help to overcome barriers to accessing mental health services? It does seem to increase the number of sessions delivered, number of children treated, and those who complete treatment. And that appears to corroborate the qualitative results, which suggested that it was overcoming barriers to accessing treatment. So does it reduce symptoms of mental health problems? So we had 16 children who were offered t-CETA, 10 of whom were randomised into the RCT, and some others who opted to receive t-CETA without being randomised into the trial. We had a mix of boys and girls aged between 9 and 17 years. 9 completed a course of treatment and 4 did a partial course, and the ones who completed treatment did 8 to 12 sessions. And this is just to give a sense of the way children were presenting. So as Stephanie outlined at the beginning, is normal to see comorbidity. So children were typically presenting with a mix of anxiety disorders, depression, PTSD symptoms, and some with conduct problems as well. Most of them had multiple problems. 4 had possible ADHD. Now t-CETA doesn't treat ADHD, but we thought this may pose a problem for delivering phone therapy. But actually 3 of those children completed a course of treatment. So with significant work from the right type of adaptations and work by the counsellors and supervisors, it is possible to do that. So in the randomised controlled trial, we had 2 measures completed by the counsellors. So the client monitoring form is completed every session to monitor treatment. And this measures symptoms of PTSD, anxiety, depression, externalizing behaviour problems and substance use. And what we saw for those children who received t-CETA, so this figure shows the trajectories for individual children over the course of treatment and the average. And we see a significant decline in symptoms over the course of treatment. We also used the Cyclops, which measures problems, functioning and well-being, and this was used at the beginning of treatment, at roughly the midpoint, and then at the final session. And again, we see a consistent decline in problems over time. So looking at the independent assessments, these were completed by interviewers who were blind to treatment allocation. We used an intention to treat design, included all children who were randomised. We used a psychopathology composite, so this was based on our questionnaires that were culturally adapted and locally validated, incorporating PTSD, anxiety, depression and externalising behaviour problems. And we had a separate measure of disability, the WHODAS. Because of the small sample size, we took a Bayesian approach, and these analyses were conducted by Claudine, who's also on the panel today. So we used a Bayesian model, which is analogous to a repeated measures ANOVA. So this is a 2x2 design where we have 2 treatment conditions and 2 time points before and after treatment. We defined what we were looking for was meaningful change, which we said had to be at least a 20% change in an individual outcome, or equivalent to a 10% change in 2 outcomes, for example. So like a 20% decline in depression symptoms, or a smaller decline across different domains. And this figure shows the whole posterior distribution representing the interaction between time and treatment for the composite psychopathology score. And just to sort of clarify this, so we have a region that we call the region of practical equivalence. This is the region where we say that there would be poor evidence for meaningful change in the t-CETA group compared to treatment as usual. But what we see is that most of our distribution sits beyond that region, which provides evidence for there being a stronger treatment effect in t-CETA compared to treatment as usual. And this shows the mean of the posterior distribution before and after treatment. What this represents is a moderate effect size. You may notice that in the control group, the pre-treatment scores seem to be lower. We did that was driven by a couple of outliers, and a sensitivity analysis removing those outliers still suggested a decent treatment effect. This was driven primarily by improvement in depression symptoms. We also did similar analysis with the disability scores, the WHODAS. We didn't find significant effects there. I've not shown that today, but that will all be published. So does t-CETA reduce symptoms of mental health problems? So the in-session assessments show a significant decline over the course of treatment. The independent assessments provide suggestive evidence for reduction in psychopathology, but not necessarily disability. And we have converging evidence from the case series and interviews with counsellors and families that all suggest that at least in some children, we're seeing a good treatment effect. So the strengths of the study, it's a mixed methods approach. So we have quantitative and qualitative data, which allows us to look at converging evidence across all these different data types. It was an ecologically valid setting. We tested t-CETA during quite a challenging period of clinic closures, and we were able to do it, continue to provide treatment despite that. We're limited by a small sample size. There was a variable delay between the final treatment session and post-treatment assessment because of everything that was happening at that point. And also because of that onset of protest between the pre and post-treatment assessments, we might expect that maybe inflated symptoms in some children at the post-treatment assessment. So that could have impacted the results as well. So just to conclude, it does seem to be feasible to deliver CETA via phone in this context, and also acceptable to many children and caregivers. Phone delivery increases access and adherence to treatment. This is suggestive and converging evidence that t-CETA is reducing symptoms. However, phone delivery in this context throws up very specific challenges that require imaginative solutions. And I'm going to hand over to Tanya now, who's going to talk through that in a bit more detail.
Hi everyone, just sharing my screen. Okay, so I'm Tanya Bosky from the American University of Beirut. I'll be talking about the practical challenges and solutions when delivering telephone CETA based on our experiences in Lebanon. And I will talk through the different parts of service delivery, from scheduling to safeguarding, and finally on adaptation of therapeutic content. Let me go to the next slide. There we go. So in terms of scheduling phone calls to start with, it was clear in this context and population that appointments that are based on a 9 to 5, Monday to Friday schedule is not very accessible. And this is the same also for face-to-face, but can be mitigated somewhat by phone delivery, as Fiona was saying, because of not needing to travel. But there was still this risk of higher cancellations and no-shows because of this restricted scheduling system. So what we found that was being more flexible in scheduling and rescheduling was really important. So setting up the service to include flexible working, to be able to provide weekend and evening sessions when needed, and to base session planning with the family on their daily schedule, and to do these appointments more broadly based on this schedule. So things like in the afternoon after school instead of next Thursday at 3 was much more practical for the family, and they were much more able to attend those appointments. And when things were more short term, so in the next few days as opposed to in a week or 2 weeks, it was also much easier to adapt to just normal fluctuations in schedules that family experience very frequently. So things like a UNHCR appointment coming up, or having an opportunity for daily labor, or all of these kind of things could impact on their accessibility to the service. So it was really important to be flexible in responding to that. And the other thing that was really important in terms of phone delivery was that we had to think about, when scheduling calls, when the family had access to a phone and an alternative phone, and when the connection was best, and to take into account all of those things when trying to schedule calls to maximize the potential for accessing the session. And then in terms of preparing for phone sessions, one of the main challenges was that there was less control over the level of privacy of phone calls on both ends, for the counsellor and for the family. So it was important to prepare appropriate spaces for the counsellor and for the family to do the call from. So for the family, right from the very beginning, we would explain and agree where the child will be able to speak from, to make sure that it was as private as possible. And then within the sessions, we would build a routine of speaking with the caregiver before and after the call. And this was to ensure that the caregiver could help us to navigate that space and to make sure that the privacy was maintained. But you also needed to work with the caregiver to ensure that they could give privacy for the child. And one of the things that helped with that was to reassure parents that there's no right or wrong answers. They don't need to check or correct what the children were saying, that they could give the children their space. And so it was important for caregivers to be involved in that process of setting up sessions to make sure that that privacy was maintained. The other major challenge that I'm sure you've all experienced now that we are all online and on the phone with the COVID pandemic is technological problems. So things like the calls not connecting or losing a connection in the middle of a meeting, someone else answering the phone or the phone just not working. So we had to develop comprehensive backup plans, both for the counsellor and for the family. And for the counsellor, this involved like having a checklist of things before every session, ensuring that the phone is functioning, making sure that it's charged, making sure that there's a headset available, and making sure that there's a backup phone and connection. For the families, the backup plan would depend on the family, and it was discussed with the family very early on. So this included things like having alternative phone numbers to call, so often just like another family member's phone number that could be called if the primary number lost connection. And then a tailored plan that would be agreed at the very beginning in terms of what to do if the connection is lost. So calling back a certain number of times, trying another number, calling back in 15 minutes and an hour. So just having a plan so that if that connection is lost, everyone knows what will happen next. Then in terms of safeguarding, the main challenge is that identification and referral of safety concerns is much more difficult without physical presence and visual contact. And so we made a number of amendments to safeguarding protocols for phone delivery. And this included things like not disclosing any information on the phone until you can be certain of the identity of the responder. We used to be able to see the person, and so the identity is very clear, but on the phone it's not so clear, and we don't always recognize voices. So we had to make sure that the identity was certain before naming what the session was about or the service that we were calling from. We also made sure to have a comprehensive service map in the location, the physical location of the child, so that if a referral was needed, then the facilitator would know which services were available, where and what time. And then we also had to make sure that a supervisor, a senior colleague would be available on call in case anything came up at that time. And we added all of these procedures also related to confidentiality and privacy into the protocols, and integrated that into training and training on safety planning that can be a little bit different when doing it over the phone. And a couple of things that were kind of different about this experience. So one is facilitators notice that they need to check in more often than face-to-face to ensure understanding, that sometimes we pick up this kind of understanding from visual cues, and that when that's not available, we need to check in more often. And we also need to follow up on kind of odd things or sudden changes. So things like increase in background noises or hesitancies, and to really go with their gut and to check and explore that the person still feels safe, that the person is still in privacy, and not just to kind of ignore and persist. In terms of adapting therapeutic content, the main challenge, that the mechanisms themselves were very easy to adapt to the phone, but the challenge was really about the duration, the length of sessions. It was just too long for the phone for children compared to face-to-face, so that we had a much higher likelihood of boredom, of poor concentration or engagement. And so the main adaptation for this was to make telephone sessions much shorter and to have them more frequent. So we divided content into much smaller components and across multiple sessions. When possible, we also sent visual materials either in person or over the phone or email if possible, so that children had something to look at to support particular activities during calls. And then one of the things that facilitators got very good at doing was to pay really extra attention to non-visual cues and to give much more verbal feedback. So things that we often will just pick up through eye contact or body language, the kind of validation and warmth and normalization that a child just no longer kind of can see, we had to make sure that that was communicated through verbal feedback. And we see that from the qualitative findings that the rapport was very strong. So this was really important for that. The last thing I wanted to mention was about just the need to keep sessions very consistent, to keep a routine, and for these sessions to be quite predictable in that way for children to stay engaged, but also to provide kind of fun incentives and things to break up the content a little bit, which included coming up with lots of games that facilitators adapted to phone use. And so I'll just end with an example of a guessing game where children would be asked to think of an object or an animal, and the facilitator would have to guess using a series of questions and see if they can figure out what the child is thinking of. And these kind of games just break up the content a little bit and keep engagement throughout the phone sessions. Thank you.
Thank you, Tanya. So I'm just, first of all, I'm just in the chat, I'm just going to share a link to the guidance document that I'm now going to talk about. So you should be able to see that. I'm also going to share my screen just with a copy of that, if I can. If I can just do this. So you should be able to see that on my screen as well. I'll just do this so you can see it properly. You know, Tanya's outlined many of the problems that we encountered and the solutions that we came up with to try and tackle some of those. And it occurred to us last year towards the beginning of the pandemic, when many services were having to transition to phone, that there was probably lots of things that we had worked out prior to that that might be useful for other services. So we decided to try to put some of this together into a guidance document, because many of these issues and solutions are not necessarily specific to t-CETA, but actually apply to many types of remote delivered therapy. So we set out this document. It's freely available, and I've shared the link with you so you can download and use that document. There's a sort of introduction in this to the you know, to the study that this guidance document has arisen from. You know, as I was saying, that many of these things are more general than t-CETA, but we do just want to stress that obviously these are issues and solutions that have arisen out of a particular context. Obviously, therapy in different settings, there may be slightly different issues. So we sort of pitched this as a starting point, just to sort of you know, sort of introduce some of these issues, but of course the protocols need to be adapted for individual services. So we've tried to set out the sort of things that we think are important to think about before delivering therapy over the phone. As Tanya mentioned, things like service mapping in the area that children are in, and developing safety protocols in advance. So, you know, knowing how you're going to manage risks remotely, and what to do if there's a risk of self-harm, for example, and how you sort of go about that. So thinking about developing these protocols. We've also set out some information about the phone facilitation skills that we think are important in preparing people to deliver therapy over the phone. So we've I'm not going to sort of go through all of this in detail, obviously, because you have a copy of the document. But the other thing we've done is taken some of those challenges that Tanya was talking about and put these into tables where we've got, you know, the particular challenges, the things that we found work best to deal with those. So we've got that as a series of tips. So we've done this for some of the sort of technical things like phone calls disconnecting, but then some of the things more specific to the therapy and the child, you know, children who are very inexpressible for the phone, for example. So we've set all of that out, and we've also put in some suggestions for sort of games and other ways to make the sessions easier. The things, again, that we found worked quite well with the group of children that we worked with. So this is some suggestions that may be useful for other people as well. And also things like following up on homework and what to do when you don't have access to workbooks and, you know, sort of hard copies of materials that you would normally use. And then the other thing that we added later, after some people asked us about this, was putting in some checklists, because it's, you know, especially when people are initially moving to to deliver treatment over the phone, it's important to really think about what needs to be done to prepare for the call beforehand, what you need to think about during the call, what needs to be done afterwards. We've also put in some information about, the criteria for working to find a safe place. As Tanya mentioned, it can be difficult to find somewhere that is private. What do you do if someone else walks into the room and things like that? So we've set out a little bit about those sort of criteria. Also developing protocols for making sure that you can identify yourself and that the client, you know you're talking to the right person, and so on. So we've sort of set these things out, and including developing emergency guidelines. So we hope that this will be useful to other people. So feel free to use this document, adapt it to different contexts and share it and so on. So that's all I'm going to say about that for now. So I'm going to hand over to Joelle now to talk about their experience. Thank you.
Thank you. So good afternoon. Thank you everyone for joining today. My name is Joelle Wehbe and I'm a clinical psychologist and a future trainer at t-CETA. So today, since I will be talking about Restart's practical experience and the implementation of t-CETA over the phone with children, I won't be using a PowerPoint like the colleagues. So it's more a time for sharing experience, practical steps in the implementation of t-CETA remote session, as well as the presentation of challenges and benefit encountered by the counselors. So a brief introduction on how t-CETA was firstly delivered to Restart counselors. Restart started applying t-CETA with adults and children in 2018 after receiving an intensive training, followed by an internal supervision and an external supervision with Hopkins University t-CETA trainers. At present, capacity building is established at Restart Center as 3 psychologists are trained to become t-CETA trainers. We have 6 t-CETA supervisors, in addition to a total number of 23 practitioners who are qualified to apply t-CETA. Some are lay workers, social workers, nurses, and we have also other are clinical psychologists. An internal supervision system is already settled within Restart Center, hoping for sure to extend to more possibilities of growth in Lebanon and in the area in order to develop and guarantee this successful program sustainability. As you may have already heard with Stephanie earlier, the specificity of t-CETA is due to many crucial factors. On one hand, it's the scientific evidence, the diversity of the mental disorders it targets, the presence of a detailed manual, the therapy lengths considered quite short, and the way it is delivered. On the other hand, the flexibility, and by this I mean the possibility offered with experience and supervision to decide on components, on the dosage and on the selection of the components. We can spice it up sometimes, and on the therapy flow. So after this quick introduction, I will move to talk in detail about Restart's clinical established experience. With the beginning of the COVID-19 spread in February 2020, Restart Center surely decided to abide by the safety measures without stopping the remote sessions. So we decided to work remotely with our beneficiaries. An internal training aimed to prepare the team to the implementation of the remote sessions. A daily 2 hours virtual training through Zoom was scheduled, including all the counselors, in order to get practical experience, to model some skills, and discuss and solve internal and external challenges in order to ensure the best practice. In addition to the online training, a telepsychology manual was prepared, including the implementation of the remote session step by step. The telepsychology manual was created based on previous studies in the domain, and it was disseminated among Restart team. For sure, Hopkins University t-CETA trainers provided Restart supervisor with their input on the implementation of t-CETA components over the phone, and a meeting was held with all t-CETA practitioners to go over trainers' note and the adaptation done for some challenging components. After a month of training, the team was ready and confident to start the remote sessions with adults and children. The total number of adults who received t-CETA remotely is 96, and the total number of children is 46. These beneficiaries completed the t-CETA therapy and ended their treatment. At present, we are still providing t-CETA sessions over the phone for new beneficiaries. What about the procedures? Sessions are scheduled on a weekly basis for a duration of 40 to 45 minutes. But as you may already heard, that sessions with younger children are usually shorter. So it's around 30 minutes. Appointments are set by the secretary 1 or 2 days before the session date to make sure the timing is convenient for the child and for the caregiver, considering the privacy and the safety measures. Sessions are done using WhatsApp application in order to have access to the camera and the video. The main problems that were addressed during that period were like safety concern, anxiety, depression, PTSD, as well as some conduct problems. The main components that were applied with children and caregivers during the pandemic especially are the cognitive coping using the TDW, what we say thinking in a different way, especially to help children and parents cope with the lockdown, the fear of sickness, the anxiety, and all the different changes in their daily routine. In addition to the application of the TDM when it's suitable, the TDM talking about difficult memories used in the cases of trauma, the getting active technique, the safety component, and for sure the parenting skills who were widely applied, especially due to the children conduct problems and behavioral difficulties. During the whole therapy period, the counselor may refer to a supervisor anytime for supervision and feedback, especially when facing a challenging case or a safety concern. Few months after starting the remote session with children, another dramatic catastrophe happened in Lebanon, the Beirut blast on August 4, 2020. Directly after the terrible explosion, Restart team was on the field to provide help and support for traumatized children and people. A big number of children affected by the trauma were referred to the center for remote therapy sessions. In this period, a lot of coping skills was used using TDW. Many components were used as well as TDM when suitable, talking about the trauma, parenting skills, relaxation, and problem solving. During remote work, as you have already heard as well, we have faced several benefits and challenges. The 5 main benefits that I will cite. Remote session gave us the possibility to reach out to people in different areas in Lebanon. This is the first benefit. The second one, remote sessions are cost-free for beneficiaries, which enhances the commitment to the session. 3 sessions were done regularly and consistently, avoiding absences or impossibility to come to the center due to financial or personal reasons. 4, both parents were involved in the therapy, and we were able to get better results concerning psychoeducation and parenting skills, especially when assigning homeworks and assigning like problem-solving exercises. Let's talk about the challenges. We also noted 5 main challenges. The first one, the internet connection, which caused an external challenge. We tried to solve it by calling the beneficiary a regular call, so not using the WhatsApp. For sure, this created another challenge because we couldn't have any access to the camera. What we did here is just sending like some visual aids, some photos later on after the session of the worksheets and of the drawings. 2, a regular t-CETA session duration is around 50 minutes to 1 hour, which was very difficult to do over the phone, especially with younger children. We tried to overcome this challenge by dividing each regular session into remote sessions, which made therapy sometimes a bit longer. 3, the lack of privacy, overcrowded houses, noises, or one phone available for the whole family affected the child's interaction and cooperation, as well as its attention and motivation. For sure, the absence of toys, of the playtime, of the possibility of interacting directly affected the child, especially younger children interaction. 4, although TDM, talking about different memory, was successfully applied with older children, it was very challenging with younger ones. And the last challenge, CMF, which is the evaluation or assessment tool used as t-CETA, was noted to be too long, especially with younger children, which causes some boredom during the session. In conclusion, 2020 has been a difficult year on all levels for Lebanese and refugees. A lot of work is needed and a lot of support as well. The number of beneficiaries is increasing every day. t-CETA has shown to be one of the most used and applied therapy by our team and one of the most effective therapy during crisis. The diversity of the components and the flexibility, as well as the experience gained by the team, helps dosing and offering the best quality of intervention. Our experience at RISTA showed that t-CETA applied remotely with children had a great success despite few challenges. No specific restrictions were noted concerning its application with children, especially with irregular supervision. We are happily surprised by the result we got from the implementation of t-CETA with children over the phone, and we highly encourage other practitioners and organizations to get trained in this approach. This is what we see with our trainees. They are very excited to be part of a t-CETA session. I would like to end my talk with 3 quotes from children who received t-CETA over the phone. The first one, you can be happy, but you have to try first. The second one, you should decide to turn a new page in your life and start talking. That's what I did. And the last one, I used to feel imprisoned. Now I feel liberated. Thank you so much.
Thanks so much, Joelle. And so we wanted to finish the webinar today with a little more information about what you would need to know if you are interested in integrating t-CETA into your programs. And I'm very aware that there's a lot of questions, and so want to make this quick while also responding to probably some of the questions that have come up in the Q&A. So when we're implementing this, I think the biggest thing is just to say that we really work with our local teams and providers who know the area and the context and the culture best. And so the first step is really this pre-implementation plan where we're working with our partners to decide on the target population, to adapt the manual, to make sure we're taking into account the environment and context, and working on what the site looks like, what sort of budget and resources and staff are required, again, depending on what that organization already has in place for their programming. I think one of the most common questions we get is who can we train? And I think with t-CETA, when we first started this, what we saw is that there really aren't a lot of mental health professionals working in the places where we work. And so we wanted to develop an intervention and a training program that can be used by lay providers. This means grade 4 educated providers. They just need to be able to speak the local languages. I would say the biggest criteria for our providers is just that they need to have time to do this and an interest. We find that things work better when we're working with providers who are really compelled and compassionate and want to have the passion to work in their communities. So there's very little required to become a t-CETA provider other than these criteria. And I will say that for supervisors, it's often the same. In many of the contexts where we work, we don't have master's level supervisors or clinicians. And so in our training process, we really work to build the skills of lay providers to become supervisors. For t-CETA training and implementation, it's again really very flexible. For the training, the number of days vary depending on how many providers you have that you want to train. It depends on whether or not you use a live training where the training is face-to-face and everybody's in a room together, versus what we've done recently with COVID, where we've had to pivot and we're working on developing a full technology app that is our training. So we still do a lot of the practice over Zoom or small group meetings, but we have a training app that we're developing that makes training much more accessible. And then of course, supervision afterwards is just so critical in making sure that counselors are continuing to use this with adherence and that they're continuing to get the support as they're seeing new and different cases. Implementation is also really flexible. As you heard Joelle said, when they were implementing t-CETA, they really realized that an hour session is too long and they had to scale back and do just 30-minute sessions. And that's possible. In some cases, to shorten the length of treatment, we do 90-minute sessions in fewer weeks. And so again, it just depends on your program. Clients can receive anywhere between 5 to 12 sessions of full CETA. It really depends on the level and severity of their symptoms. But also, we do offer CETA short sessions, which are one-off sessions. We have an SBIRT, which is a substance use intervention that's a 30-minute session, and it's a tier 1 intervention. We also have a CETA short session that we offer in groups as a way to do some preventative work as well as coping. So there, again, a lot of flexibility in how this is implemented and rolled out. I know one of the main questions that came up was also around how do you handle high-risk situations and safety, and that is obviously always our first priority. So we work with organizations to make sure that we have a very specific safety protocol before we start, and a referral system that just helps providers to know who do they contact, when do they need to contact them, what are the laws, what are the reporting requirements, and that they're trained in how to deal with those crises. And obviously we want to know what we're doing works. And so things that an organization needs to consider is just making sure that we have an M&A system in place to recruit clients, track them, make sure using the client monitoring forms to make sure what we're doing works, and really using that as a process to fix and to make some of these, to address some of the challenges that are coming up. So M&E systems are really important in programming. And I know a lot of what Fiona and Tanya and Joelle were talking about is a lot of the special considerations for telehealth, so I won't go as much into that, but just to say it's important if you just want to implement t-CETA that you're taking into account the need for confidential space for your providers as well as clients, the equipment, the need for phones, the need for electricity in order to charge those phones, and things that we don't always think of or we take for granted. So with that, I'll just end because I know there's several questions and we want to be able to answer them. But if you want more information on CETA, again, please feel free to visit cetaglobal.org or contact us. Thanks so much.
Thanks so much. So we're now in our Q&A session, but I'd just like to thank all the presenters for the excellent presentations. As you can see, there's a lot of work that went into this study. It was a very challenging study for many different reasons. Obviously, we've been affected by the pandemic. We've been affected by the political crisis in Lebanon. And before that, we've been affected by snowstorms that prevented families from going to clinics and many other challenges. But we've been resilient and have overcome. And thanks also for all the questions. And I noted a few of the general themes that we will discuss in the next few minutes. So the first question is about cultural considerations. So what are the cultural considerations to be looked at for the delivery of t-CETA? So that involves adaptation to the specific context, but also the background of the counselors. And I'm wondering whether maybe Stephanie or Tanya would like to share something on that and keep it short. I encourage the whole panel to switch on their video.
Sure, I can just speak for CETA more generally. I think that we see, again, when we work with organizations, that it's really a process of adaptation. And we know CETA, but we don't know CETA in these contexts. And so we really rely on our local providers to give us feedback and to help edit the manual and make sure that we're incorporating all of these things in there, as well as our organizations on the ground to inform us more about the providers and what they might need and what backgrounds they're coming from, so that, again, the training is tailored to the needs of the people that we're working with.
Thank you.
I would just add, yeah, I think what was clearly important with the families that we were working with is that there is the kind of collective side of culture that's so important, the family, the caregivers, and that until we engaged with parents, there were a couple of questions in the Q&A about caregivers and parents, and it was so important for them to be on board, even though the intervention is targeting more children. Parents needed to be really engaged in what was happening, and fathers as well, like, not to neglect the kind of more systemic side that's so culturally important. Nicola, maybe, I don't know if you want to add something to that.
I agree with what you both said. Culture, to be able to be culturally sensitive to the traditions as well, and the system of values and thinking of the families. So no matter, it doesn't matter how we think in this equation, it only matters to respect the values that they uphold. Whether be it in the simplest of ways, like saying hi to someone, or how to what words we use, especially that there was a lot of different dialects used. So that as well. That's it.
Great, thank you. Yes, I think I'd like to just emphasize that a lot of our work went into the cultural adaptation of the program. That took a long time to do, and we, with a lot of involvement from Nicola, Diana, and Stephanie, counsellors who obviously know the local culture very well and were very much involved in making the program as culturally relevant as possible. So that's a very important aspect. The next question, Tanya, you mentioned a little bit about the caregivers, and I thought we've spoken a lot about the children, but actually t-CETA, a very important component is the caregivers are involved. So I wonder whether maybe again, maybe Stephanie or Joelle could share a little bit about how caregivers are included or were included in the treatment and the importance of that, and how that is relevant or different from other treatments. Maybe Joelle, you want to start?
Yes, sure. So especially with younger children, the intervention is mainly sure with the child, but mainly with the caregiver, because we have a lot of parenting skills in the manual. We have different techniques used with the parents to teach the parents how to work with children, especially when they have some difficulties, some behavioral difficulties, struggling with the communication with the parents. Sometimes the parents are overwhelmed by the children's actions or behavior because they didn't understand why the child is doing this. So we have this psychoeducation. We need to psychoeducate the parents about what does this mean for the child, and to give them options to normalize for sure some behaviors in the way. It's very clear in the manual. We have the what and the why, and it's very clear to explain it's very important also to explain every step for the parents. They will feel like confident partners in the treatment. And when parents, and especially both parents, are involved in the treatment and they know why we are using this step or this technique, what does it mean, what are the benefits of it, they will be much more involved, and the child will feel like really supported. As well as for the homeworks. In t-CETA, we have like weekly homework that we give for the children as well as for the adults. So especially with younger children, and even with the older children, we need the support of the parents to remind the child of the homework, to be like spending some time with the child. So this increases a lot and enhances the benefits of the therapy. And for sure, every session we need some time to spend with the caregiver and another time to spend with the child.
Go ahead.
Just add in, I'll just add in really quickly that I think the approach is really that when we're doing cognitive behavioral therapy, we have a child for a very short amount of time, and the parent is really the one that's going to be with the child for longer. And these skills aren't skills that can just be used right in the moment to help the child with distress. But if we teach the parent these skills and they're engaged, they're going to be able to help their children through moments in the future that happen. And so caregiver engagement is really important to us. It's something that we work on throughout treatment. I will say though, however, with evidence-based treatments, what we see is, well, outcomes are better if the caregiver is engaged. It's if the caregiver can't be engaged, that we still see positive results. And so we still see that the treatments can be effective if we have caregivers that either aren't available or appropriate to engage in treatment.
Thanks a lot. There was also a question about client commitment as the lack of client commitment as a barrier. And that is definitely something that we've encountered as an issue. We had a lot of people that initially said they would like to receive treatment, and only a small proportion of them ended up doing so, even when delivering t-CETA. So I think that told us that it's not just, you know, we can't overcome all the barriers with phone delivery. There is a lot of psychoeducation and awareness of mental health problems and treatment thereof that needs to happen in communities. I don't know if anyone else would like to share anything more on that. I don't know, maybe Fiona, or on the client commitment.
Yes, Michael, I would like to add one more thing about what you said. Sure, we have some drop sessions, we have patients who drop, or children, but these are some of the internal or external challenges that the child or the family may experience. And we can work on these external if we have a space to talk, a time to talk, to understand why they cannot commit. If there are any internal challenge, we can do some work on internal challenge, like what do they think about the therapy? How can we change, we psychoeducate? And if there are any external challenges, like they don't have any, like they cannot recharge their phone, at restart sometime we can send like $1 to talk for a certain period of time. So we need to ask what are the challenges, and we need to work on these challenges in case they are external or internal. We do what we can. Sometimes, yes, when we work on the challenges, we can get them engaged and they will be committed again, but sometimes for sure we can't do anything. Thank you.
Thank you. There's one question about the fathers, and maybe Fiona, you can share a bit about what we've experienced about the role or the importance of fathers.
It might be better for one of the clinical team actually to comment on that. So maybe Nicola, or just given that you were dealing with those issues more directly.
Thank you. I can answer that, and Diana can help me out as well. So we noticed that when the fathers are engaged, the children are more likely to adhere to the session. And when the fathers are not interested, the children are far more likely to drop out, even if the mothers were on board. Diana, if you want to add any examples, if you have, or anything else.
Don't know if Diana's trying to answer.
Yeah.
Do you have anything to add, Diana?
Hello. Yes, as Nicholas mentioned, when the father is interested, the kids became more committed to the sessions. And for my cases, I actually remember in CETA, most of the kids came with their fathers, not with their mothers, for my cases in CETA.
Great, thank you very much. Well, maybe the last question that I have for the panel is, should we prioritize phone delivery over face-to-face even once the pandemic ends?
It's a challenging question. So I can give my opinion and my experience. I think it shouldn't be like the first solution or the first therapy, but it could be one of the choices or one of the options for the parents who cannot come, or for children. I think even after the pandemic, we can privilege the face-to-face, but we can keep also the remote session and phone session. It's an option, and a very good option for some families. But I think the humanitarian, presence and the contact and the verbal, non-verbal, the presence, playing with children is essential. And for me, I see that it's a priority. So this is my opinion from our experience, but for sure, if you have any other.
If I could.
Yeah, go ahead, Fiona. No,
yeah, I was just going to say just a quick comment. So from the thematic analysis that we did, what the sense that we got was that you know, there are many families who would prefer to do face-to-face therapy if that was possible, because there were so many difficulties with them getting to clinics. The reality is a lot of those families maybe would have come for 1 or 2 appointments and then dropped out, which is what we saw a lot with the face-to-face treatment. So many of those children just wouldn't have completed a course of treatment otherwise. So it feels like it might be a good option to do those initial appointments face-to-face, but have that option to go into phone therapy later, you know, or mix and max if necessary, but just to help some of those children finish the course of treatment rather than dropping out early, which I think is the real risk otherwise.
I just wanted to briefly add that, you know, the whole idea behind a public health intervention is we want to increase access to care. And the great thing about this is you can do both. You can be trained in CETA and know how to do tele-CETA, and you can reach more clients this way. So I think that that's really our emphasis, is how do you create an approach where we're just increasing the access for these populations to quality evidence-based care.
Great, thank you very much. At the outset of this research, our question was, is it possible to deliver therapy over the phone in humanitarian settings? It hasn't really been done before. I think now we know it is possible, not just because of our study, but because everyone has been forced to do so during the pandemic. But I think our research and the hard work that went into adapting an existing treatment for delivery over phone has shown it is possible to do so, and it has advantages. It's not the solution for every situation for every child, but definitely an important tool in the toolbox of MHPSS. Well, I'd like to thank all of you for attending, and all the presenters and panelists for joining today and giving their time. We are at the end of the webinar now. It is recorded. You'll receive a message in the next day about where you can download, or where you can watch the webinar. We will provide more information if possible. This is ongoing, so you please check on the CETA website, and keep checking with Restart in Lebanon if you're interested to deliver t-CETA in Lebanon. And we will publish our research findings in multiple ways. So keep checking back on our website and you will hear more about that. And I'd just like to thank everyone that has been working on this project, which was a very challenging project, but we've managed to do it. And I also like to thank all the participants of the research, all the Syrian families that have been absolutely brilliant. And yeah, so thanks a lot for joining in and for listening to us and hearing more about our research project. And hopefully we'll have similar webinars in the future where we update about the next steps and additional work that we're doing. So thank you very much and all the best. Bye-bye.